Well, hello everyone and welcome. My name's Jane Taylor and I'm from UPMC-Children's Hospital of Pittsburgh. I'm going to be one of your moderators today for the Peds Assembly Town Hall, and we are co-hosting this with our friends from the International Society for Heart and Lung Transplant, and we're very excited to have them joining us. And we are going to be talking about pediatric lung transplant, what's new and what's next. It's going to be based off of their new consensus guidelines that they just had come out for referral and selection of pediatric lung transplant candidates. So today I am co-moderating with my friends Dr. Adrienne O'Hagan from the University of Louisville, Dr. Ann Coates from the Barbara Bush Children's Hospital, and Dr. Kimberly Pereira from UPMC-Children's Hospital of Pittsburgh. We have Dr. Jessica Reyes, who is going to go over the consensus statement for us. And she is from UPMC-Children's Hospital of Pittsburgh. And then we have a group of panelists who also were on the consensus statement gathered so we can talk through it and at the end answer questions. So as questions come up, please put it in the chat and Dr. Pereira is going to read them at the end. So for our panelists today, we have Dr. Nicholas Abdemiritz from British Columbia Children's Hospital. So welcome, thank you. We have Dr. Christian Bendham from Boston Children's Hospital. Welcome. We have Dr. Don Hayes from Cincinnati Children's Hospital Medical Center. And then Drs. Kurland and Dr. Midyat, both from UPMC Children's Hospital Pittsburgh. So welcome, everyone. And we also have Dr. Bridget Willemse from Beatrix Children's Hospital. And we're just very excited to have everyone here today. So Dr. Reyes, we're going to go ahead and let you get started.
Okay, so good morning, everyone. Today I will be giving a very brief overview about the changes in lung transplantation epidemiology. And I will also be highlighting the most important points from the newest consensus statement on the referral and selection of pediatric lung transplant candidates. So a little bit of history first. So it's been over 50 years since Dr. Hardy and his team performed the first lung transplant in a human being. However, it's important to point out that we didn't have any significant progress until early 1980s in lung transplant world when we had the development of more effective immunosuppressive therapies and also improvement in the surgical techniques. And it was only until the early 90s that lung transplantation started to make its way into the pediatrics world. In this slide on the right side, you can see that lung transplantation has definitely lagged behind the successes with other solid organ transplantations, and these can be explained by different factors. One of them is that we know that lungs are continuously exposed to the outside environment, and this definitely puts them at higher risk of developing infections. Another important key factor is that while surgeons, they need to create bronchial anastomosis and heal them, and this is very particular to the lung transplants that we don't see in any other organ transplantation. And the other part is that it is important to note that during this lung transplant surgery, the original blood supply of the lungs are not reconnected during the surgery typically. Here we can see that over the past few decades, lung transplantation has grown dramatically. You can see the adult data on the top and the pediatric data in the bottom. And if we see at the adult data, we can see that in fact, by 2019, we had a 6-fold increase in the lung transplant recipients when compared to 1992. Most of these global growth in lung transplant volumes are mostly driven by the adult lung transplantation. If we look at the graph in the bottom in regards to the pediatric numbers, we can see that the pediatric transplant volumes are going to opposite side. They are moving towards a reduction in the number of lung transplant. And this basically is attributed to the improvement in cystic fibrosis care and the development of more effective CFTR modulators. So if you see my screen here with this arrow, just to give you an idea, around 2010s, in early 2010s, we used to have 60 to 80 lung transplants per year, but most recently, since Trikafta era, after 2019, we have been having more closely to 40 lung transplants per year. When we look at the reasons why children receive lung transplants, well, historically, cystic fibrosis have been the leading cause for lung transplant, but as our experience and our knowledge started to expand, so have the conditions that are now treated with lung transplantation. And nowadays, we know that even infants with congenital lung disease or end-stage lung disease are now considered for lung transplant. Here, I would like to point out the significant impact of CFTR modulators on lung transplant volumes across different age groups, and this is based on UNOS data here in the United States. And in 2013, if we look at the pediatric population, that is the purple line at the bottom, cystic fibrosis made up for about 70% of all lung transplants in the pediatric population. But after the Trikafta era in 2020, this only accounts for about 15% of all the lung transplants in the same population. Most recently, we are also seeing that childhood interstitial lung disease has been becoming a more common indication for pediatric lung transplantation. So according to the UNOS data that is displayed here in this slide, in the early 2000s, we had that child accounted for about 4% of all the lung transplant in the pediatric population. And most recently, in the period between 2020 and 2024, this is accounting for about 26% of the total patients receiving lung transplants. And this is basically due to the fact that we are now more aware of this illness, we have better diagnostic tools, and we are getting better in doing transplants in younger patients. Pulmonary vascular diseases are also becoming a larger part of the pediatric lung transplant indications based in US data here displayed in this slide from UNOS database. We can see that from 2020 through 2024, pulmonary vascular diseases were accounting for about 21% of all the lung transplant indications in the pediatric population. In terms of survival, the post-transplant 1-year survival in the pediatric lung transplant population has also been improving throughout the years. As we can see here with the blue line, in the early 90s and 2000s, we can see that the 1-year survival rate was about 75%, and most recently, between 2018 and 2023, it has been closer to 90%. So based on these data, we can clearly conclude that the landfill of pediatric lung transplantation is changing and is changing very, very rapidly. And breakthroughs like CFTR modulators have significantly reshaped this field. They are reducing the need of lung transplantation in patients with cystic fibrosis, and they are shifting the major indications toward child or childhood interstitial lung disease and pulmonary vascular disease. And Well, these shifts are extremely important. They matter. And the reason why they matter is because basically they are redefining who needs to be transplanted and when they are going to be transplanted. And because of this, a new consensus statement was recently published to help guide us when to refer these patients and who are going to be good candidates for being listed for a lung transplant. So here I am going to give a very brief review of the most important points in this statement. So in terms of the referral, the key factor here is that the panel recommends that referral needs to be done early. And we know that whenever we delay this referral, patients can miss that window for a successful transplant. Another important factor of this statement is that they recognize that children are not just small adults and that they have unique conditions that need to be considered, such as developmental stages, growth potential, that they also have rare diagnoses that we are not going to see in the adult population, and that family support and caregivers are a key factor for transplant success. This consensus statement also includes different psychosocial factors or a framework that includes non-modifiable, non-compliance factors, addictions, including vaping, and family support. This statement also provides specific recommendations about listing that we were lacking this particularly in the pediatric population. And a key factor here is that listing should be considered if we think that there is a greater than 50% chance of mortality within the next 2 years, or if we think that the quality of life or the functional status of the patient is going to decline significantly despite maximal therapy on these patients. The guidelines also emphasize that extracorporeal life support is not an absolute contraindication per se. Of course, if we are talking about specialized centers, and that we can consider this as a bridging option in patients that are unstable to get to a lung transplant. And basically, another important key factor is that having extracorporeal life support is going to change the timing and the listing decisions in these patients. They also mentioned that patients with a history of cancer or malignancy is not an absolute contraindication for having a lung transplant, but we need to consider key factors such as metastatic disease or residual cancer. Here we will reassess the recurrence risk of that malignancy, and we will need to be working very closely with the oncology team. In terms of HLA mismatch, this is also not a contraindication for lung transplant, but we know that this is going to need an early and aggressive planning before considering these patients for lung transplant. This consensus also acknowledges that we have certain infections that are going to pose an increased risk in patients that undergo lung transplant, but they are opening opportunities to consider lung transplantation in patients which historically would have been excluded for having a lung transplant. It also makes very clear that we always need to assess the infection risk, especially after the transplant immunosuppression, whenever we have multi-drug resistant bacteria or problematic infections like fungal infections. Another important point of the statement is that they consider that prior thoracic surgeries are not an absolute contraindication. And of course, we will need to analyze case by case, and that we will need a special expertise in the surgical team to proceed with this lung transplant. Here in the statement, we also have that infants can also undergo lung transplant, and we are seeing a growing numbers in lung transplantation in infants. Now that we are mentioning that childhood interstitial lung disease are one of the major indications or growing indications in the most recent years. The guideline also includes a section on multi-organ transplantation. And basically, it states that those patients that need a multi-organ transplant, probably they will need to be referred earlier than any patient receiving only lung transplant, since we will need a more interdisciplinary team taking care of these patients. And finally, when it comes to lung retransplantation, these consensus are giving very important guidelines. One of them is that we need to be clear that retransplantation is something that is not routine, is not common. We know that these patients have a higher risk of mortality, so this is exceptional and it should be considered like that. The other important part is the statement is very, very clear that we always need to ask, why did the first graft fail? And depending on this, then the group can decide if the patient will benefit from retransplantation. Another important factor that the statement is considering are the ethical factors to have a patient receiving another lung transplant. And here is going to be very important, not only knowing the family desires, but also the patient desire of getting a retransplant. And retransplantation only should be considered in patients that in hospitals that have big experience in this setting. Thank you very much.
Great. Thanks, Dr. Reyes, for that update. Again, for the audience, if you have any questions, please put them in the Q&A section of the Zoom feed. As Dr. Taylor said, we are privileged to have with us today a group of international experts in the field of pediatric lung transplantation. You guys can open up your videos and microphones. I'm not going to reintroduce you since Dr. Taylor did such a great job, but thank you all for being with us today. Let's start by expanding on the current state of pediatric lung transplantation. As Jessica mentioned, cystic fibrosis was once the predominant indication for lung transplant, but there have been striking shifts over the past decades. Would the panel like to expand on how referral patterns and patient demographics have changed over the last decade or so?
Well, look, let me take that as so nicely. Dr. Reyes has actually referenced a couple of papers that my very dear friend and colleague, Dr. Avdemiris, and myself have put together over the recent years. Obviously like to thank the organizers for inviting me and for this excellent initial overview that was so comprehensive in the given time limit. Like as we all know, like cystic fibrosis was really the indication, and if you look historic data in the United States, about 50% or so in pediatrics. Outside, because I'm actually a European, so I practiced until recently in Europe, it was even 60%. And so just to give you a number, when I moved from Zurich to Boston, in Zurich, the last pediatric patient that underwent lung transplantation for cystic fibrosis occurred in 2018. And the last patient with cystic fibrosis who underwent lung transplantation here at Boston Children's was in 2019. So you see, it's a very similar pattern. And that is obviously thanks to the excellent, like care now in cystic fibrosis and the introduction of these highly effective modulator treatments. And I think personally that has very much changed my practice over the last years. Then I'm actually a lung transplant NCF provider, and obviously, been in this business for well over 2 decades. So I don't really see children referred with cystic fibrosis anymore. I see very frequently, as we highlighted in the papers, patients with pulmonary hypertension, patients with interstitial lung disease, and patients are more complex. So just to make it a bit more concrete, so the last 3 patients, just out of the head, that underwent lung transplantation here at Boston Children's were patients with PH, surfactant B deficiency and a patient with a retransplant. This is also something we're going to face, more in the future. 2 of these 3 patients were on ECMO support. One of them was even centrally cannulated, which shows you, the complexity and the severity of those patients being referred, and they're getting more complex. One of them being the smallest child ever undergoing lung transplantation here at Boston Children's with only 5 kilograms. So you can imagine that this has surgical and management implications that are very severe. And we tried with this international consensus guideline to somehow reflect those changes, that occurred, and trying to incorporate that, even though we have to admit that many of the things we've done, this is an expert consensus statement because there's a lack of very solid data. There's a lack of RCT data. So this is very much, built on the expert consensus. And given the fact that in the United States, I think last year, only 24 of patients, pediatric age, underwent lung transplantation, shows you that these numbers are small. There are only very few centers providing this. And that also has implications for, training future leaders in the field. And with that, I'm sure that Dr. Avdemiris has more to add because he's, an expert in this area as well.
Well, no, I completely agree with the picture that Dr. Bendon painted just now. And I just want to commend Dr. Reyes for the really beautiful presentation and summarizing everything like Chris said. I think it's really interesting when we look at some of the granular data from UNOS. Dr. Reyes presented the overall picture. Looking back to the past couple of decades, it's interesting to look at some of the peak years in the US, according to UNOS data. So peak years for pediatric lung transplant. And those years were back in 2003, 2009, and then 2013. And for those years, as Dr. Reyes alluded to, CF really led the number of indications, the indications for those transplants. In 2003, across all of those transplants, 70% of them were for cystic fibrosis. And then looking at the absolute numbers in the US, 30 to 35 were the peaks for CF-related pediatric lung transplants over the past couple of decades. You're looking at in 2021, there were only 4 pediatric lung transplants done for CF. In 2022, again, 4. 2023, 3, and then in 2024, only 1 pediatric lung transplant done for cystic fibrosis. So I think the numbers are actually very striking when you look at just absolute number of transplants. And then I think the other picture that Dr. Reyes pointed to very nicely is the increasing proportion of PAH and PVD patients being transplanted and ILD patients, in addition to other conditions like bronchiolitis obliterans. So this really led us to embark on this landmark ISHLT consensus statement. I'd love to hand it over to Dr. Hayes to discuss maybe some of the international data that exists on some of these trends.
Well, thank you. Thank you, Nick. Thank you, everyone. Really a privilege to be with this group, and thanks to the ATS and ISHLT. The speaker did a fabulous job. Overall, the numbers looking at what we're looking at, the volume, I think, like we've talked about, we reviewed it. The volume, actually, the most recent numbers are going to show that we're continuing to climb in the total number of lung transplants performed in children. So the next consensus document, the next registry report for the ISHLT will show that the trends are continuing to rise. And so it's these other diseases that we're capturing. I'm in the same boat as Chris reported with what he's been doing in Boston regarding the number of transplants. We're doing more ILD. If it says anything, their last 3 lung transplants here in Cincinnati have been for ABCA3. And for some reason we're in an epidemic of ABCA3. In a large part, I've started to partner more with our ILD team, more of our rare lung disease team, as well as our PH team. We're kind of one continuum of care here is how we've kind of structured it. And so there are other patient populations that need this particular surgical treatment. And so we anticipated that with where the growth would be, and that's exactly where we're seeing it. I think one patient population, I think, is still on the small number side that's continuing to rise, is those that are critically ill. Like what Chris says, we have a kid centrally cannulated here that we're ambulating, trying to rehabilitate. He's been on the wait list for greater than 7 months and been on a circuit for greater than a year. And so the biggest challenge that we're experiencing right now in pediatric lung transplant is the small donor pool. So this is one thing that we could actually help each other. Besides, maybe if you have a kid with a particular condition that you think may need a transplant, it's great to send them early, but also be an advocate for pediatric organ donation wherever you may be. And so that's one thing I wear on my shoulder as an advocate for those, because these are kids that are needing transplant. These aren't adults. And so that's something to consider. And I'll pass it on to my next colleague, whoever may want to speak. I know Jeff's always got some color in his words.
Well, I don't have much color in the words, but I point out, I think the things that we're all noticing is the decrease in CF patients because of the efficacy of the modulators, but they don't cover everything. One of our recent patients is a CF patient who doesn't qualify for modulators. And I know Vertex is still working hard to expand those mutations that will be affected positively by new modulators. And I can anticipate that will help us out in the future. We have seen a large increase. Well, we don't do a lot of transplants, but a significant increase in those patients with pulmonary hypertension, pulmonary veno-occlusive disease, for example, leading to pulmonary hypertension that have required transplantation. I think one of the many challenges we face is that of lack of donors, and I would like to underscore what Don has said. I think it's one of our responsibilities should be the continued support and advertisement, if you will. That's not the right word, but spreading the word that pediatric donors are lacking. Even for the few patients we have, just the length of the time that our patients are waiting is still very difficult, especially for patients that, for example, that Don described, those on extracorporeal membrane oxygenation support. But I certainly agree with all the statements that have been made so far, and I'll let someone else take over. Brigitte, you on?
Yeah, I would like to thank everybody as well to be here. It's very nice and a good discussion. I do agree on especially what Don Hayes said just a few minutes ago. That it's also very important to collaborate with all your colleagues who are specialized in PH or ILD patients, so that these patients get referred early. I think that's nowadays one of the things we more and more realize as well. Like I'm from the Netherlands in Europe, and since we have more closely collaborations, we are more able to save those children by doing a transplant. So I think that's another good point to raise here. And next to this, I want to add that our patients are getting more and more complex. CF is less, despite we also transplanted 1 year ago a girl who was not eligible for moderated, but that's very rare the last 5 years. But we get more and more complex children also after chemotherapy, radiation pneumonitis due to kidney disease, kidney cancer, or that kind of children. We get more and more here. So I think the group of patients are changing.
If I can add, I know that Levin's on this call, and he perhaps can talk a little bit more about some of the other things that we've done here at Children's to expand those patients who can receive transplants. Levin, are you on?
I'm here. Thanks again. And Jessica, it was a great job, by the way. Very great summary in 15 minutes. CF numbers are not just declining in the pediatric patient population, it's also in the adults. Like instead of like 250 transplants per year a few years ago, now it's down to like 50, 60. And I don't think it's just the modulator, it's also like we have more expertise, like more nutritional care, diabetes care, airway clearance and everything. And we hope that it will be the same thing for other diseases as well in the future. But there will be years that you will have like an ARDS outbreak or something like that. You never know. So we should be ready, but we are getting sicker and sicker patients, and we are shifting our focus from the like the typical indications for transplant to the ones who are dying because of respiratory diseases, because we don't give them any option because of the other complications in the other organs. So one of the things we are doing here since 2014-15 is especially for patients with rheumatological disorders, immune deficiencies, immune dysregulations, if they have end-stage lung diseases because of this, because of the autoinflammatory process or because of the complications of the immune deficiencies, we have a program which is relatively still like a small program, but we do first lung transplant and bone marrow transplant, and we have a protocol for that. And I think many other centers are interested in this. I know UK is interested in this. Yael reach out to me. Yeah, I'm emailing you, by the way. So like they're from Israel, like many other centers are interested in this, and this will increase the patient population. And I think once we have a good protocol and once we have more expertise in this, this can really change the future, I think, of transplant, because if the bone marrow transplant works, if you have good engraftment, you can even wean off all the immunosuppressions. We are one patient from 2014. She's off immunosuppressive for the last like 5-6 years. She's doing well because the bone marrow transplant is from the same donor. So it's the same donor from the bone marrow transplant, and the lungs are from the same donor. So there's no rejection there, as long as the bone marrow continues to work well. So this is one of the other patient population, and many centers in the United States do like 2-3 transplants per year, but this doesn't mean that we don't get referrals. Like this year, we got almost like 15 referrals, really. Not referral doesn't mean evaluation. Evaluation doesn't mean listing, but in the statement, you'll see that again and again, we say early referral because these patients are becoming more complicated. If you refer early, at least we can start the conversation. We can meet with the family. Like when the time comes, we are ready. If there anything we can work on, nutritional, rehabilitational, or other things, we can start working on them as early as possible. But just to start the conversation, whenever you are in doubt, you can reach out to one of the teams, and most likely one of these doctors also dealt with one of these patients in the past because of our expertise, because these folks usually deal with the sickest patients in the pediatric pulmonary world.
I just want to maybe just talking about the cystic fibrosis. Someone mentioned before obviously the impact of these modulators. Just putting my hat on as the immediate past president of the ISHLT, so the International Society for Heart and Lung Transplantation. There's still countries and areas around the world where obviously these modulators are not available. And so I think we always have to be aware, and I think our guidelines, the ones we put together, these are international guidelines. So we certainly have to, bear this in mind. I've recently been invited to speak at the Brazilian Transplant Conference in Fortaleza, speaking to the colleagues there. That's a bit of a different picture. So I think it's very important that we, as we are a small international community, very closely collaborating, we know each other, and we're all friends and colleagues. I think it's very important that we have everyone on board, that we leave no one behind, and really also keeping some of the expertise up. That's kind of difficult, as Levent just said, because there are so small numbers. You need to train your juniors. You still need to keep up the capacity to look after those patients. And if you then have someone in your team who actually tells you, oh, I've never seen a post-transplant lymphoproliferative disease in my training, then this is not because they're poorly trained. It's just because we're trying to avoid this these days. And obviously, if the numbers are small, then you don't see it. So which is another thing. The second point, I think what Don mentioned, I think is super important, is that, making sure that donations are growing as well. I noticed since I relocated from Europe to the United States that here there are more smaller donors available compared to Europe, which is a good thing. But also we need to make sure that pediatrics is well, participating in donors and, the donor sharing, which is, I think, another important thing. Dr. Abdemirs and myself, we've recently looked and published, the donation allocation policies around the world. And not everywhere around the world, pediatrics is prioritized. That's another important thing, so that we make sure that, in particular, if you go to the group where small adults could also take pediatric organs, that here children are not disadvantaged. That's another important, aspect. I think
those are great points, Chris. And I want to build off of what Chris just mentioned around CF timing of listing. I think is really important. This was a really difficult topic for us to broach in the ISHLT consensus document. Previously, there was a recommendation, and Brigitte, feel free to jump in on this, to likely list pediatric patients with cystic fibrosis for lung transplant when FEV1 was less than 30%, which is a great recommendation to have up until the era of highly effective CFTR modulators. And now times are changing because we're seeing CF patients at any age doing quite well on CFTR modulators with FEV1s in the high 20s and not requiring lung transplant and just cruising along. And then on the flip side, as Jeff mentioned, there are some patients who actually don't do as well, have comorbidities and things, and their lung function continues to decline. So it was actually very difficult to come up with a consensus statement across all CF patients. And what we came to after much debate, much discussion, and a deep dive into the literature was really that this needs to be determined on a case-by-case basis. Early referral is still extremely important, but listing is much more difficult. I just wanted to point out that very important piece.
I've got no comment on that, Nick. I think you put it precisely how it is. I think it's always a case basis, not only for patients with CF, but also patients with other indications. And the earlier we can see them, we can decide whether we need to list them. Great, thank you.
I feel very superfluous to this conversation. We're running out of time. So in terms of surgical advancements and emerging technologies that are beginning to redefine what's possible in transplant, such as ex vivo lung perfusion, xenotransplantation, et cetera, hoping to expand donor pools, what gives you optimism about the next generation of transplant care in pediatric lung transplants?
I guess I could probably answer that. We're one of the pediatric centers that's used ex vivo lung perfusion widespread. We've done our last 5 lung transplants using the device that's available. We work with one of the service providers in the United States, and literally it opens up this donor pool for 3,000 nautical miles. So all our donors, actually, we're getting more donors from the West Coast than we are from the East Coast, if it says anything. And so it's an opportunity for those kids that are our kids are having longer donor wait list times, waiting on a potential donor. And so with that, we've used this as a resource to be able to go and grab those. And if it says anything, our warm ischemic times are shorter with the device than they were with ice. And so if you look at specific approaches, and so we've been very happy with the service. We've been aggressively trying to expand it. I'm actually converting some of my research into that and meeting with one of the service providers to discuss opportunities. But this has certainly opened this up for us here. I think other institutions are looking at this. It's more widespread in the heart side for kids, but I think at some point, it will grow a little bit more on the pediatric lung side, but I don't know what other institutions are doing. This is something we've not actually talked about as a group. But we're very happy with it here, and I think it's going to be something moving forward. I don't think it's the answer. I think some of it is just it's an opportunity or resource available for kids, depending on what the circumstance are. And I think it's literally case by case basis, but every one of our kids that we've used it on, it's assisted in getting donors earlier.
I think it's a very good point, Don, but I would even take it a bit broader and just say, overall, I think maybe, and that's I learned from my years in adult lung transplantation, very often we're just too conservative because we talk about, like the ideal criteria donor lungs, and these, based on an ISHA consensus document, this is, based on expert opinion. It's like 3 decades old. And even when I was in Zurich in an adult center, we've been much more aggressive because of the low donation rates anyway. So the utilization rate in Switzerland was up to 45%. So, which is really high compared to, other centers. And that even without, using EVLP, even though we had EVLP available for many, many years because it was a self-made kit, actually, not even a, commercially available one. And this is a great opportunity. And I think the other thing we have to, because of our small numbers, as Levent mentioned before, we have to collaborate, I think, well with adult centers as well. So I'm coming from a center where lobar transplantation, cut down lungs have been very common. For us, it wasn't anything specific new. So we've used that in the adults, we've used this in the children, and we've, I think at that time, pioneered it, even that one that we once took a 1.80 m donor and then had 2 ECMO runs in parallel, and we transplanted the 2 lower lobes into one adolescent and the 2 upper lobes into a girl. And this occurred, if I recall now correctly, in December 2010. So this December, those 2 recipients will be 15 years out. Both of them do very well, and they do both of them not have chronic lung allograft dysfunction. So I think you can just really pioneer this, and I think it's very important to be aggressive with that. So I see, the EVLP, yes, I see more using extended donor criteria. The Hanover group have nicely put this together as well a couple of years ago, that their outcomes are comparable, which is great. Lobar transplantation, cut down lungs, these are things ABO incompatible. I think we're much too conservative. We just done one recently here, which was a little one, but I think in the heart groups they go up to 2 years or so. So I think there are multiple ways of, I think, extending the donor pool and avoiding exactly what unfortunately Don was describing before, which is these super long wait times of patients on any kind of support, and then making the rehab, obviously much more difficult, and the likelihood of them, having complications from the support higher.
Yeah, I utterly couldn't agree with Chris more. We've got criteria that is listed as what we call marginal lungs. And I don't like that word, but that's what they use for years. And that doesn't mean that it implies that organ is not usable. And so we've transitioned to this extended criteria donor lung. And I think we as a pediatric group, I think all of us need to learn from each other. And like what Chris is saying, even in Australia, their conversion rate from a donor into an actual transplant is greater than 55%. So other countries are leading this. And this is including pediatric candidates that they have listed at their adult hospital in Brisbane. So I think there's a lot more for us to continue learning and growing. And we have more tools that are at our disposal. And so Adrian brings that excellent point up with that question.
I'll also add to what Don and Chris mentioned, Toronto certainly has a very thriving EVLP group, and they've had some very good success at shortening waitlist time for pediatric patients and having really excellent outcomes. So that's another center to look at in terms of the data. The other thing I'll add, Chris mentioned lobar transplant, and I think this is probably a good time to talk about the work that our Japanese colleagues are doing on living donor lobar lung transplant, which is extremely interesting. Prior to 2010 in Japan, there was this kind of cultural phenomenon, and by law, deceased donation was not allowed and not accepted. And so for many years, Hiroshi Date and Satona Tanaka and their group across Japan, they've been performing living donor lobar lung transplants for children. They recently published their data on 70 of those cases in pediatrics, which was really astounding, and their outcomes are really fantastic. So I think this is another avenue for our international pediatric lung group to look at. It's not something that has had an extreme amount of uptake in other countries due to possibly some ethical determinants and surgical expertise and those kind of things. But I think it's a really interesting avenue based on their positive outcomes.
That's great. Thanks for the discussion. I think let's open up for questions from the chat. Looks like we have about 10 minutes left. If there are any questions, Levent, you can make your comment.
No, I was going to say that Dr. Tanaka, I think, is one of the listeners as well. They are doing an amazing job. I think EVLP will open the door for many other things as well. It's like in Toronto, they were using it as a car mechanic shop. So they get the organ. If there's any pneumonia, they treat it. And then after that, they send the organ to Chicago. They treat it there. They get it back and do the transplant. But also DCD donors, like many other solid organs, are now accepting that. But as the lung folks, because of the ischemia time, and all the other injuries, we are very concerned about that. Donation after circular third death with EVLP, with the help of EVLP, those things, we can expand that donor pool as well. But pediatric centers have limited resources compared to adult centers, so not every center has the luxury of having EVLP. But I know that the adult folks are working on more minimally invasive techniques, more robotic surgeries, more smaller incisions. And they are not saying no to many other previous contraindications for surgeries in the past. And we are accepting more donors, more organs, some infectious causes, some other things. In the past, we were saying no, but I think as the expertise grows, we feel more comfortable with accepting those organs as well. Hep C was one of the stuff, some certain infections as well. So I think our knowledge is expanding, our collaborations that are expanding, and this group, everyone from UK to any part of Europe, to South America, North America, Australia, Japan, and we know each other very well. It's a very small group of pediatric lung transplants folks, and we discuss every patient with each other. If we are in doubt, we learn from each other, and it's a good way to stay alive here, but also to, again, learn from each other's expertise.
I don't see any questions in the chat. So I guess I had a question.
To Adrian, if there's nothing in the chat, then I think one of the things you mentioned, and it's because it's so much in the press now, is this xenotransplant issue. A kind of a delicate, I don't even want to touch on the ethics and things like that. And together with my dear colleague Simon Urschel from Edmund, we recently put an opinion piece in, published in a journal, Heart Lung Transplant. Obviously, when you think of ABO-incompatible transplant in children, you think that, xenotransplant might be, applicable because, there's also this mismatch, with the polysaccharide antigens of porcine origin. But we don't really know the impact of xenotransplantation, in particular on the developing immune system. That's a big unknown. And so, obviously there's so far only adult data, and then we don't know if this is different in children then. And then obviously the risk of potential zoonotic, infections makes it also, more complex. So I think for now, looking just at the next 5 years, let's put it that way, I think we should rather explore all these options that my colleagues and friends have just now all highlighted, EVLP, extended criteria lungs, lobar transplantation, these kind of things, rather than, banking on that avenue. Certainly within the next 5 years or so, that would at least be my take on that, even though obviously we don't know the the immunologic opportunities that are there, but it might also harm the developing immune system.
Well, thank you. I had a question regarding the donor pool. Have you guys noticed a change in the number of families that are signing up for a donor pool over the past 10 years, i.e. since COVID? for example? Has that changed either in the United States or internationally?
The only thing I know that the only data that I know that I've been following is registered donors, and the numbers are steadily stepping down. There's been a trend downward for the last 10 years, and it continues to have a downward trajectory. Outside of that, I don't know anything about where we can get data. I don't know if there's a specific question you're focused on. Are you?
No, I was just concerned about the sort of changing political climate, particularly in the United States, with regard to medical care, and whether it's impacting on families willing to sign up for donor pools.
We do know that the registered number of pediatric donors are declining. And what is another interesting thing, and what I'm experiencing personally on a day-to-day basis, is the what I would describe that extended criteria for donor lungs. There seems to be more of those. They're not as normal, crystally clear lungs that are being offered like they were 10 years ago. I don't know if the others in the group or online that may be attending the meeting, if they've experienced the same thing. So it's more donors. So we got fewer donors, and the donors are more extended criteria. And that's my personal experience.
Yeah, I agree with you on that. One thing that I noted here now in the United States, obviously it hasn't been that common, but I think is DCD donation. I see that at least increasing here, which is great, because this was very much a backbone, for example, of donation in Switzerland. You know, without DCD donation, it would have been really difficult for us because of the super low donation rates, and they're obviously very different and heterogeneous across Europe. When you talk about like Spain, who is a world record holder in donation, and then countries like Germany, where this is very poor, in particular that there's no DCD donation available. So I think this is difficult to address, and of course, I mean, political climate plays a role. For me as a foreigner in this country, a green card holder, it's very difficult to comment on that. But certainly it does play a role also with regards to other issues such as vaccination strategies and acceptance of vaccination in preparation of transplant. But then, as I said, for a foreigner, in this country, it's a bit difficult to comment on that.
For the attendees, DCD means donation after circulatory death, and then that's very different than brain death for those that may or may not understand the difference. But circulatory death is much more a complicated process in order to declare, and it's a little bit more controversial, and there's some ethical questions regarding in children. And so actually, we have listed our first DCD candidate. And so we're using that as a potential experience now to try to see if it can help us with a donor pool here in Cincinnati. And so, but it's widely used outside the U.S. It's growing favor, meaning donation after circulatory death, but it's been growing favor in the United States. But our colleagues across the pond have been users of this for a much longer time with much more success, and the outcomes are the same. And so it takes us a lot in the U.S. to wrap our mind around doing something a little bit different. But our colleagues certainly in Europe have been champions for this, and it's a good reason why. And so we're trying it here in Cincinnati to see if it's a possibility for our program as well.
Especially when we are listing for double organ transplant, like heart and lung. Our heart folks here, they do DCD. We don't do DCD, and when you do heart and lung, the waitlist time is usually longer.
Yep.
And they want us to think about that even more.
Yeah.
Like we are of course hesitant because of the history, because of all the data in the past, but things are changing really. Whatever we were hesitant 10 years ago, we are not saying no anymore. So yeah. This will be one of the other steps in the near future.
And he makes a great point on that. That's exactly. We have a patient here also listed for heart lung for DCD. The other thing is the ABOI. ABOI is incompatible ABO. We just basically freeze off those antibodies targeting the red blood cell antigens. And so our heart colleagues in the US and in Europe have been doing this for a lot longer time than we have. And so we actually have our first heart lung infant listed in quite some time that we've listed as an ABOI here. So we're going to see what that does as well moving forward for potential offers, because a heart lung offer for an infant is going to be quite challenging in today's environment.
I think we noticed in the Netherlands, at least, that the changing of whether you have to opt in or opt out for donation changed a lot. We had an opt out, we had an opt in. So people had to say before when they wanted to be a donor or not. And now we have an opt out system. And since then, our offers are, well, at least for the adults, are much higher. So wait lists are getting lower, but we have a small number of children, and that's depending on the size. Luckily, I'm working together with our adult center and also our surgeons. So we do have the opportunity to do lobar and surgical volume reduction surgery. So I think in the end, we haven't seen any changes the last 10 years, but I know that especially for the change in opt-out has raised the donor numbers a lot. And we do use the DCD donors as well.
I love that opt-out option. I think we'll close it there. So I just wanted to thank everyone for an incredibly thoughtful and really forward-looking discussion today. What we've heard underscores just how dynamic and rapidly changing the field of pediatric lung transplantation has become. We clearly heard how essential collaboration is, especially in a low-volume, high-complexity domain like pediatric lung transplant. And we are clearly practicing at a time where the traditional indications for transplant are shifting, where surgical innovation is expanding what's possible, and where advances in immunology, donor management, and perioperative support are really changing how we think about risk and long-term outcomes. And I think as we look ahead, there's tremendous reason for optimism. So thank you to our panelists for sharing your expertise, to the organizers and the ATS for this platform, and to the audience for your engagement and dedication today. For your colleagues that were unable to join us today, a recording of this town hall will be available on the ATS website shortly for their viewing pleasure. And as we close out 2025, happy holidays to all. May your celebrations be joyful and your pagers stay silent. Until next time.